Okay. So anyway, so I want to take today to briefly talk about the last section here. This is I'm hesitant to tell you this, but like, so there are no questions on the test specifically from this section, okay? And so you're like, great, I don't have to worry about it. I still want you to worry about it. I still want you to at least be checked in and listen to this, because this is like super important stuff in terms of getting into Pharm 1 next semester and helping to set you up for success. The reason why I say that is, and you're like, well, I already learned autonomic nervous system stuff from Professor Kaplan. Like, why are we re-reviewing it here? I want to illustrate to you why this is so important from a drug perspective, because if you don't have a good understanding of how the autonomic nervous system is, you're going to be sort of behind when we're learning about just a ton of different classes of meds. So, like, meds that affect the GI tract, meds that affect the urinary tract, meds that affect the eyes. Like, there's just so many things. Yeah, I know it's not recording. I'm recording on my end, so I'm going to post that up as a separate video. Um, so anyway, so this is why it's super, super important to understand this stuff, and I want to kind of illustrate some of those points there. So I'll make some examples as we go along of why I think it's sort of important. You know that there's sort of two main branches of that sympathetic or the autonomic nervous system. There's the parasympathetic and we have the sympathetic. So when talking about parasympathetic, this is our rest and digest, right? So this is where, if you're just kind of had a big meal and you are resting, this is where you're going to be able to digest all those foods because you're sending signals to the GI tract. You're sending signals to various places, and so that way you're in a more of sort of a parasympathetic state. The main neurotransmitter to focus on here, though, is going to be acetylcholine, right? Or I had a professor in college called acetylcholine, but you sound kind of silly saying that. So I say acetylcholine. And the main receptors that is going to be found here is the nicotinic and the muscarinic. I don't know if anyone has any idea of where the nicotinic receptors come from. Anyone? Anyone? Probably nicotine, right? So actually, nicotine was like the first thing that we actually found that interacted with those receptors, which is why we called them nicotinic, right? So we're gonna find those are the two main important ones there. Then for the sympathetic, there's the fight or flight response, right? So if you bear were to jump out of your closet, the fight or flight response will be signaled. The main neurotransmitter you're going to see here is norepinephrine, right? So I say norepi, that's a kind of a shorthand way to reference that. Epinephrine is similar in activity. You'll see that it activates a similar set of receptors, but those are going to be for more sort of like slower but more sort of prolonged, sustained sort of sympathetic effect from the adrenal glands, right? And we'll see there's some direct innervation of the adrenal glands there as well. And so the main receptors here you're going to find are alpha 1 and 2, and then beta 1 and 2. Those are the main ones. And again, you probably already know they have pretty distinctly different actions in terms of what they're doing. And so looking at this, and what's really kind of interesting is you can see too how the nicotinic receptors are still involved actually in both parasympathetic and sympathetic conduction here. So for instance, if we were to look at a parasympathetic signal, you can see here that's coming from, say the spinal column, going out and releasing acetylcholine directly on to these nicotinic receptors on the ganglion. So we talk about the preganglionic transmission here, as I'm going to mention. This is where that's getting activated, and then that will then trigger that nerve to release acetylcholine onto muscarinic receptors, right? So if it's in the GI tract, it's going to cause increased peristalsis. It's going to increase secretion of the salivary glands. It's going to cause all kinds of things, right? So you're going to see a lot of smooth muscle activity going on in terms of both of these systems here. Here you're going to find that with the sympathetic signals, one, we can have direct innervation of the adrenal glands. So that is predominantly going to be releasing epinephrine. And again, that's for a more kind of like longer, sustained sort of activity here of like regulating blood pressure and heart rate and things like that. But you actually notice here too, the nicotinic receptors are also involved preganglionically speaking when dealing with the sympathetic nervous system. So you can actually see here too that when you're looking at things like nicotine, if you were to smoke a cigarette, which I don't encourage any of you to do, but you also notice some of the things that it does is it kind of like mellows you out a little bit, for sure. Like sometimes it has an anxiolytic effect on people, but also like it raises your blood pressure. You're like, why would it do that? Well, it kind of makes some sense here because you can see here there's nicotinic receptors preganglionically that can affect that sympathetic nervous system. And then too, it gets a little bit more complicated for things like sweat glands. Like, we'll see that the muscarinic receptors here are really important for causing secretion. So that's affected for sure. But more importantly, we're going to see that the smooth muscle and like cardiac muscle and things like that are going to be affected by norepinephrine being released from these sympathetic nerves directly onto the tissues itself, right? So kind of keep in mind the differences between the preganglionic transmission, which is always through acetylcholine in these nicotinic receptors, and then depending on if we're talking sympathetic versus parasympathetic, you're talking about acetylcholine on muscarinic receptors or norepinephrine on alpha and beta receptors, essentially. Okay, so you guys already know that. In terms of biosynthesis, this is also really important because if you understand the biosynthesis, you'll understand how certain drugs can come in and affect this, either to potentiate the activity of the system or maybe to actually inhibit it depending on the situation. So in the development of acetylcholine, you'll see here that it's basically you're just putting acetyl-CoA plus choline together, acetylcholine, pretty straightforward. And then when you're breaking it down, it's via this enzyme acetylcholinesterase. And here you're going to find this is a really big spot where we can actually affect the system here. So I can do things that maybe helps to speed up the activity of acetylcholinesterase, or I can do things to slow it down. And so what would happen if I were to slow down acetylcholinesterase activity? Well, basically, you're not going to be metabolizing this as quickly. I'm going to have more acetylcholine around, and then that's going to be meaning more of it's available to interact with things like muscarinic receptors and nicotinic receptors. And so we're going to see that it can lead to certain side effects being seen here. It can lead to certain therapeutic effects being found here. Sometimes you want that extra effect around in order to help stimulate those muscarinic receptors, for instance. On the other side, if we're looking at the development of norepinephrine, have you guys heard of the term catecholamines? Anyone familiar with what that means? Basically, it kind of refers to a set of chemicals that share sort of a similar structure. And if you were to look at, say, the structure of like dopamine and norepinephrine and epinephrine, they share sort of a similar structure because they share a similar lineage here, right? So, for instance, like tyrosine, which is an amino acid, can be converted into L-dopa, which is eventually converted to dopamine, which we know dopamine is really important for like movement. We know it's important for like the reward pathway, but that then can be further converted over into norepinephrine. And that's going to be that main neurotransmitter we mentioned for sympathetic effect. Okay. And again, I'm going to get out of this and talk more about actual clinical implications here in just a little bit. So hopefully I don't lose too many of you just talking about this stuff. Now, again, when you're looking at acetylcholine and how it's affected, it's mainly going to be metabolized pretty quickly by acetylcholinesterase. This is like one of the fastest enzymes in the body, actually. But for a lot of other neurotransmitters, we try to be more sort of conscientious about recycling and reducing the amount we actually have to produce. And so you find that for a lot of the catecholamines, we try to reuptake as much of that as we can. Same thing goes for things like serotonin. So if you've ever heard of like a serotonin reuptake inhibitor, it's interrupting this process here. We try to recycle and reuptake a lot of these different catecholamines. But if that does not happen, how do we break it down? Well, we can do it via two different enzyme systems here. So we have like catecholamine O-methyltransferase, or COMT, and then you have monoamine oxidase, or MAO. And so these are two really important ones that metabolize things like norepi, things like dopamine, things like epinephrine, things like that. And then again, in the adrenal medulla, this is where norepi gets converted into epinephrine. So you can kind of see that common lineage here between all of these catecholamines. So this actually becomes really important too. So for instance, like MAO is also responsible for metabolizing serotonin, right? So when we start to look at behavioral health meds, probably in the winter semester, I believe, you actually find that by inhibiting the activity of this enzyme here, we can raise up levels of things like norepinephrine and serotonin. And what does that do? Well, it actually treats depression. It was actually the first set of drugs that we had to treat depression, whereas to inhibit this monoamine oxidase enzyme to raise those levels up, and all of a sudden we found patients' depression symptoms got better, right? Yeah, so you mentioned SSRIs, working through that system there. So nowadays we have different ways of treating that, but that was sort of the first initial way we had to manage that. So you want to know like how these things are being formed, and you also want to know how they're being broken down, right? Because that balance needs to be maintained, or we could affect it directly by introducing drugs into the situation, right? We can try to maybe inhibit this enzyme, or maybe I'm going to try to inhibit acetylcholinesterase to get different effects out of the body. So I kind of want to cover different organ systems here so that way you kind of understand what are the main effects that you're going to see here if you were to modify these systems, either make them work more effectively, or if we were to introduce drugs that could affect this, right? So talk about the eyes first, kind of breaking them down into what the sympathetic and parasympathetic effects are. So typically in the eyes, this is going to be important, especially when we talk about glaucoma, as well as a few other things here too. But for instance here, when you see the parasympathetic effects, you're going to see constriction of the circular muscles of the iris, right? So what's that going to do? Well, it can lead to meiosis. Right, so that's actually one of the things I look for. If I had someone who was exposed to a drug that, say, decreased acetylcholinesterase activity, leading to more acetylcholine around, affecting these muscarinic receptors, well, one of the signs I could see in the patient, they have meiosis. So if I see that, it could lead me to believe, okay, they have these really pinpoint pupils. What's going on here? Could be related to this, right? Also, you're going to see these effects accommodation and can affect things like lacrimation. So you may see a lot of extra tearing if you were to have increased activity here. But does anyone know, I'm sure most of you had eye exams at some point in your life, and they've dilated your eyes before. Well, how do they dilate your eyes? Well, there's two ways they could do that. One of which was to actually inhibit muscarinic receptors there. So they can give you an anti-muscarinic drug, and that causes the eyes to dilate, and that way they can get a better view of the eye itself, right? The other way, though, we could actually affect this is with the sympathetic nervous system. So we can do things like cause radial muscle contraction that causes mydriasis through alpha-1 receptors, or we can also cause some ciliary muscle relaxation, which again helps with accommodation via beta-2 receptors. So it's still norepi affecting the system here, but it depends on the receptors that it's hitting, right? So in the case here, alpha-1 receptors tend to constrict smooth muscle. We'll find beta-2 tends to relax smooth muscle in a lot of situations. So go back to the eye dilation example. Again, I could either do something that blocks the parasympathetic effect, or I could do something that activates the sympathetic effect, right? And so I could do something like phenylephrine, which is a sympathetic drug that causes mydriasis to occur, right? Or I can give something like atropine to block the parasympathetic effects in order to cause that mydriasis to occur. And it's actually interesting because you get different effects here. So if you've ever had a dilation done and like you're basically out of commission all day long, it was probably related to anti-muscarinic drug because it has such stronger effects on accommodation than something like a sympathetic drug does. It lasts maybe for a couple hours or so. So again, you can get different pharmacologic action depending on kind of which system you're trying to interact with. The heart is really, really important. We're going to talk about this extensively when we get into the cardiac section. So what happens if you're activating parasympathetic effects on the heart? Well, you're mainly going to be activating those muscarinic receptors, and it's going to cause decrease in heart rate, decrease in contractility, right? So you're going to be causing decrease in cardiac output. Overall, it can lead to hypotension as sort of a secondary effect. We see this a lot in patients. Or actually, one of the main drugs you would use, say, for instance, for someone who is bradycardic, is something to actually block these effects, right? So if you ever heard of the drug atropine before, anyway, you with experience in the ER have probably seen this before, you can actually give atropine to block these, and what does that do? Well, it's going to raise heart rate back up, right? So again, if you have an understanding of these systems here and how the drugs interact with it, you'll have a good idea of the clinical effects. What about for the sympathetic effects here in the heart? Well, mainly you're going to see mostly beta-1 effects, okay? So again, a common thing I hear for a lot of students to help remember this is I think beta-1 on the heart, I got one heart, and then beta-2 on the lungs because I got two lungs. So if that helps you out, that helps you out. But the beta-1 effects typically will increase heart rate, it will increase contractility. So for instance, if I were to give someone an epi drip or a norepinephrine drip, that would then increase heart rate contractility and then should have also an increase in heart rate based on that increase in cardiac output there. Okay, so typically sympathetic you're going to be finding will raise the heart rate up. But if I block this system, what if I give a beta blocker? Well, it's going to block those beta-1 receptors, and that should cause decrease in heart rate, decrease in contractility. Right, so you got to have to understand sort of what's happening if I'm activating it and then if I'm blocking it as well. So looking at the blood vessels too, this is going to be really important. For parasympathetic, not a whole lot of direct innervation here, so this is not so much to worry about. But sympathetically speaking, yeah, you want to know about that. So typically, you're going to see that blood flow will be redirected based on sort of where it's needed. So in general, if you only could operate two organs to keep yourself alive, it'd probably be the heart and the head. So when you have a fight or flight response signal here, one, you're going to try to pump blood to those two organs, and then you're also going to be pumping blood to places where it's needed, like the skeletal muscle, right? So if that bear is hopping out at you from the closet, you can run away from that, right? You can supply a lot of oxygen-rich blood to that muscle. So we'll see that through alpha-1 activity, So norepi and epi acting on alpha-1 receptors, you're going to cause this increase in blood pressure, but also decreases blood flow to certain non-essential organs. So for instance, like, do I need to worry about digesting any food while I'm in a fight or flight response? Well, not really. And so you're going to divert blood away from areas like that in order to pump it over to the skeletal muscles. That's why a lot of people cramp up after physical activity when they've eaten, is because they're not digesting that food that's sitting there in the GI tract. But how does that balance occur? So sure, it can activate alpha-1 receptors to decrease blood flow to those organs, but if I want to increase blood flow to other places, that's where my beta-2 receptors come into play. And again, generally, alpha-1 constricts and beta-2 relaxes smooth muscle. And this is the same thing here, where you can find that this will increase the diameter of the vessels, will allow for more blood flow going to certain vital places, right? And so this gets really important too, because one thing you'll find for patients who are, they have hypotension, say they have like sepsis or something, and they're having sort of this body-wide vasodilation occurred via inflammation. One of the things you'll see is that certain non-essential organs, quote unquote, can really take a hit because they're not diverting enough blood flow to those. And like the kidneys are a really big one. So what we'll see is frequently with patients like sepsis, we'll give them vasopressors, we'll give them supplemental norepi or epi to try to increase his blood pressure to the vital organs, but it will shut down blood flow to places like the kidneys. So that can lead to decreased creatinine clearance. And what does that do to our drugs? Well, then that can extend the half-life of certain drugs, right? We have to account for it. It also decreases blood flow to the GI tract. So that puts them at risk for things like stress-induced ulcers, where they can develop decreased blood flow, decreased wound healing, and then get a peptic ulcer as a result of that. In addition to some other things going on. So again, that's the main thing you're going to see with the blood vessels there. In the lungs, we'll see that the parasympathetic system is working on those muscarinic receptors to cause bronchial smooth muscle constriction and also to stimulate bronchial secretions, right? So you'll find this a lot is that patients who have like really junky sounding lungs, it could be related to some of these parasympathetic effects here. On the flip side, though, with the sympathetic effects, we can cause beta-2 activation to relax the bronchial smooth muscle, which makes sense if you think about asthma. We mentioned like albuterol inhalers before, and they said that's a beta-2 agonist. It'll activate those receptors and relax that smooth muscle, so that way we can move more air about. What's actually really cool is that one of the ways that we can diagnose asthma is by actually activating this parasympathetic system here with a drug and seeing how they respond to that. So if there's a drug called methylcholine. So methylcholine kind of sounds like acetylcholine. It has some cross-reactivity with those receptors. I can give a patient methylcholine. If they develop an asthma attack, they start to wheeze and all of that, then that shows that they are really sensitive to that. And then I can give them a beta-2 agonist right after. And if I reverse it, then I kind of have a good idea that they do have actual asthma. It's actually diagnosed that way in some cases there. So again, some ways we can provoke this, which sounds like bad. Like, why would you want to give your patient asthma attack? But if for a diagnostic purpose, that could be useful here, as long as you got the meds to reverse it when you need to. The GI tract, this is going to be a big one, especially when we talk about antispasmodic drugs, when we talk about diarrhea, when we talk about constipation. This is going to come up quite a bit. And so we're going to see parasympathetic sort of is the main player here, where it's mostly muscarinic effects we're going to see. And again, when you activate this, you're going to see increased motility and tone. It's going to lead to sphincter relaxation, increased secretions, just increased movement altogether. And so this is where you can give drugs that activate the parasympathetic nervous system, and diarrhea is going to be a really frequent result of that, right? So if I give something, for instance, that blocks acetylcholinesterase and lead to higher levels of acetylcholine, diarrhea is a really, really frequent consequence of that as a result of these effects on the GI tract. Overall, though, on the sympathetic side, you're going to find decreased motility, tone, and secretions, which makes sense because, again, if you're in a fight or flight response, you don't need to worry about digesting and moving things along there. And you'll see that the sphincters are constricted by that alpha-1 receptor activity, right? So again, alpha-1 is constricting smooth muscle generally. Beta-2 will then relax it. So that's kind of the way where you're going to see those main effects from that standpoint. Again, a lot of drugs are going to be affecting this, a lot of antispasmodic drugs. So if you ever have someone who like comes in complaining of cramps and things like that, frequently we'll give them anticholinergics in order to help deal with that, to help slow that down. But also, if I'm giving someone anticholinergics and I'm decreasing motility and tone, guess what a common side effect of that is? Well, then it's going to be constipation, right? So that's going to be a really common issue with that. And actually, I had a patient, or I had a relatively distant family member. I think I might have mentioned this already, but they were on chronic pain meds. They're chronically taking opioids, which is, just so you know, is really constipating. It's like the number one side effect. And they kept complaining. They're like, man, I got all these stomach cramps. I need something that can help out with these stomach cramps. And what do we do for cramps mostly? Well, they're usually anti-spasmodic, anticholinergic agents. But, then we asked the question, well, when's the last time you had a bowel movement? They're like, oh, it's like been a week. I was like, well, wait a second. If I give them an anticholinergic, that's going to slow things down even more. That compounds the problem. They're going to have even worse cramps because they got a belly, they're FOS. They're full of stool. They got to get rid of that stuff. So what was the answer for that person, right? Well, it wasn't give them an antispasmodic. It was to clear them out. Give them an enema, give them some stool softeners, all of that in order to help kind of flush things through. And then all of a sudden, guess what? Abdominal pains all the way fixed. So sometimes it may be counterintuitive to think, okay, well, they got stomach cramps. Actually, I may need to stimulate that GI tract more than inhibit it, and depending on the situation. For the urinary tract, this is going to come up a lot when we're talking about like urinary incontinence. We're talking about like benign prostatic hyperplasia. It's going to come up pretty frequently there. In terms of parasympathetic effects, again, it's mostly muscarinic. We'll find that this one's a little counterintuitive in terms of other things we've been looking at so far. But when you think about parasympathetic effect on the urinary tract, typically what you're going to find is the muscarinic effects will cause constriction of the detrusor muscle, which you're aware that that's basically we're going to be constricting the bladder to cause to expel urine, and actually relaxes the internal urethral sphincter, right? And that's the involuntary one that we don't have any like direct control over, as opposed to the external one that we do have some direct conscious control over. So you can find too that, again, if I have someone who has too much acetylcholine activity, say they were exposed to something that blocks acetylcholinesterase, frequently, they're going to have incontinence. Is going to be a side effect of that. They're going to increase urination. I've had patients who were exposed to certain substances, and basically they just had, just liters of urine they're producing over what they normally did because of this extra parasympathetic effect here. On the other hand, though, the sympathetic effects here, you're going to see that actually beta-2 activation on the detrusor muscle will relax it, and that actually helps to hold on to more urine. So it actually helps with storage in these cases here, and then will cause contraction of the internal sphincter so that we are holding on to it. So the detrusor muscles are relaxed, so your bladder is larger, and then you're also constricting down on that internal sphincter to keep it there, right? So that way it's going to get better storage. And when you're trying to run away from a threat or something, you want to keep blood volume up, right? Because you need to be able to perfuse those muscles with oxygen-rich blood. You don't want to get rid of volume. And that main way we get rid of volume is through urine, right? So, some things kind of make sense if you think about it from that fight or flight or rest or digest sort of standpoint. So, looking at the skin, we'll see here from a parasympathetic standpoint, again, mostly muscarinic effects, and overall generalized secretions. So, diaphoresis is going to be the most common thing you're going to see with this. So, if you have someone who's like kind of sweating excessively, it could be related to this increase in parasympathetic tone here. And one of the things that I think students may not always have a good grasp on is that it's not like it's 100% sympathetic or 100% parasympathetic. It's kind of a generalized tone. You can have both being activated at the same time. It's more so of which one is more kind of predominant, right? Which one am I more expressing at the time, depending on the situation, sympathetic or parasympathetic here. In terms of sympathetic effect for the skin, overall, you're going to find that you will develop like a piloerection that can be as a result of alpha-1 activation here. And you may see some localized secretions, but overall, you're going to see that you're not going to get the same sort of diaphoretic sort of effect here. And again, some certain things can override this, right? So I can see someone who does a whole bunch of cocaine and is having a very high sympathetic tone at the time, they're still going to be really diaphoretic because they're going to have hyperthermia as a result of the drug exposure as well. So just because you don't see someone sweating or not doesn't mean you can necessarily tell what this is from. But certainly if I had someone who's exposed to like an anti-muscarinic, they can certainly have really dry skin. They may have really dry mucous membranes, and that's one of the ways I can kind of tell, like, what kind of substance might they have been exposed to potentially. So some other sort of miscellaneous effects here, you're going to see that with the parasympathetic side of things, salivary gland secretions are going to be increased here. So frequently if someone's exposed to an anticholinergic, so for instance, like a good example of that are antihistamines. So a lot of your first generation antihistamines like Benadryl, for instance, or diphenhydramine is generic. One of the big side effects you'll see there is going to be sedation for sure, but also you can see things like dry mouth, right? And so that is mainly related to blocking this activation of the salivary glands. And on the reverse side of that too, you can have increased salivation as a result of overactivation of the system as well. From the sympathetic side, usually for skeletal muscle, you're going to find that this increases contractility and also glycogenolysis. This is actually really important from a blood sugar standpoint, right? Because if you think about when you're in a fight or flight response, you need blood sugar, right? You need fuel for the muscles to start moving around. And so we can do things like activate glycogenolysis and increase contractility of the skeletal muscle. But also, more importantly, where do we keep a lot of our glycogen for our blood sugar? Well, we keep it in the liver, right? So you can see here that by activating the liver from a sympathetic standpoint, you cause glycogenolysis and gluconeogenesis to occur. And so this is actually really important because what you find with patients who are hypoglycemic, frequently the response to that is you activate the sympathetic nervous system, because we know that by doing that, you can cause a rapid increase in blood sugar as a result of breaking down that glycogen there. So what's interesting too, though, is that if I have someone who is a diabetic and they're getting hypoglycemic, but say also they're on a beta blocker, you can actually inhibit this and actually lead to even more profound hypoglycemia because they can't really respond that effectively by causing gluconeogenesis. So again, some of this is like kind of more nebulous. I'm talking about it. We'll get into the really specific examples next semester. I just want you to have kind of a good understanding of sort of the basics of the systems here in terms of how it relates to medications. Another one too is the concept of autoreceptors. I'm not familiar if you guys have heard of the term autoreceptors before, but basically, I might do a little drawing here in a second, but see, Kaylee says, so what about, what would be the explanation? I was so scared I peed myself. That contradicts the sympathetic. So is that an example, like you said, a parasympathetic taking over? Not necessarily. Sometimes you may find, too, if you get scared, like everything kind of tenses up, so if your abdominal muscles were to tense up, that may override, that the pressures in the bladder causing the override of that internal urethral sphincter. So it could be something related to that too. So there could be some other things at play there than that. That's actually a good question for sure. But basically, and you guys are familiar with homeostasis. I know I've mentioned it a few times here, but let's say I have a presynaptic nerve, and then I have the nerve terminal here. I know you guys are probably pretty impressed with my art so far. But basically, you're going to see, who knows if she was being personal or not? Who could say? But we'll assume anonymity here. But basically, you have your postsynaptic nerve terminals here, which may be like an alpha 1 receptor or a beta 2 receptor or something like that here. But what regulates how many of these neurotransmitters we're releasing? Because again, you'll have your little vesicles here full of neurotransmitter, which then get released out to here. And you'll have uptake transporters, which can then recycle them back in to put them back into a vesicle, right? So it's kind of the normal cycle here. But what shuts down further release of neurotransmitters from these vesicles here? Well, it's actually you have these like little autoreceptors that reside over kind of on the side here of the nerve, presynaptic nerve. And once these get activated, it kind of says like, okay, we got enough neurotransmitter being released around here. Let's go ahead and shut off further release. So it's kind of like when you're thinking about like thyroid hormone, right? If you have enough T3 and T4 floating around, it's going to then feed back onto the hypothalamus and say, hey, we don't need to produce any more TSH here. We're good. Same thing happens here, but on a very kind of small scale within this nerve. And so these autoreceptors are really important because if I activate them, then I can then shut down further release of things like norepinephrine. So we call this a sympatholytic effect. Right? Sympatholytic meaning kind of stopping the sympathetic nervous system activity here. So alpha 2 is really, really important for that, for some of our drugs. So if you've ever heard of the drug clonidine before, this is a really good example. Or there's a drug called guanfacine you may see used for like ADHD occasionally. It actually activates alpha 2 receptors to feed back and stop release of norepinephrine. So what does that do essentially? Well, it decreases sympathetic tone. So one, you may see sedation associated with that. Or if you have someone who's like really hyperactive, it may kind of chill them out a little bit. But also you can see things like bradycardia and hypotension as a result of that, right? Because now you're not just working on the individual tissues. Now you're working from the CNS down to decrease sympathetic outflow. So you can have body-wide effects by doing that, which is why you can see both that combination of bradycardia and hypotension as a result of that. So for instance, I had one patient who had accidentally, is a 10-month-old, I believe, had ingested a clonidine patch that had belonged to the father, kind of dug it out of the trash, or I think the sibling might have fed it to him or something, but had ingested it, and the kid came in really sedate, and was relatively bradycardic and hypotensive. We actually ended up having to admit him and having to manage that for a couple of days until he actually pooped out the patch 2 or 3 days later. So again, alpha 2 activation here is super important for a few drugs that we'll talk about in the cardiac section later on. So, what are some mnemonics that I like to use to help me remember different effects with both the sympathetic and parasympathetic system? Well, for the cholinergic effects here, this is what I use, right? So, for one, I use the dumbbells. Some of you may have heard the term sludge before, which is sort of an older term one. But I like dumbbells because it includes the killer bees, as we like to call them in the tox world. So, what does that mean? Well, again, this makes sense if you remember all the things we've already talked about. So one for D, it's defecation, right? So you can see diarrhea as a result of that increase in peristalsis on the GI tract. You can see urination because you're squeezing down on that detrusor muscle and relaxing that internal sphincter. You see meiosis because we talked about the effects on the eyes, causing constriction of those circular muscles. We can see, and again, the killer bees here. This is something that we talk about in the tox world because, again, you'll find that patients it's hard for them to really pee themselves to death. But if you are not perfusing the body because you're so bradycardic, or if your lungs are filled up with fluid, you can't really oxygenate all that well. So here we have bradycardia, bronchorrhea, and bronchospasm. Right, those are really strong cardiac effect or cholinergic effects you can see directly on the lungs and on the heart. You're also going to see emesis, so they'll typically be vomiting as a result of increased GI activity, lacrimation, and then salivation. Okay, so those are the dumbbells for the cholinergic, more specifically the muscarinic effects, right? So these are muscarinic receptor effects specifically. But what's interesting too, if you recall back to that slide where he talked about sort of like preganglionic activity being related to nicotinic effects, this is where we're going to have a little bit of sort of activity that seems almost at odds with what we're talking about with the muscarinic effects. So you think nicotinic, you think, okay, it must be parasympathetic, but not always, right? Because some of those sympathetic nerve terminals were being innervated with nicotinic receptors, right? So I like to use the days of the week for this one. So for instance, if I'm activating nicotinic receptors, initially what you actually will see is mydriasis, right? Because it's actually activating some of those preganglionic sympathetic fibers there to cause mydriasis to occur. You can see tachycardia, because again, you're going to get overall stimulation on the heart specifically. You can actually see weakness and paralysis from that. This is going to be more so to do with skeletal muscle activation. If you recall back from when you learned about that, that nicotinic receptors lie on that motor end plate, and activation of that causes skeletal muscle to contract. If you overdo that, you can actually wear out those receptors and actually cause weakness and eventually paralysis. And this is actually what will kill patients, is their diaphragm basically becomes paralyzed over time. There is Thursday, I guess I kind of fudge this one a little bit, but you can see hypertension as a result of this, and then fasciculations. And this kind of goes along with that skeletal muscle activation where you saw with the weakness here. So, and again, this is kind of odd because if you were to say, for instance, there was a chemical warfare attack, and let's say someone released sarin gas on a public crowd or something like that. What's interesting is that initially you end up seeing the sort of nicotinic effects, and sarin is a acetylcholinesterase inhibitor, so it's increasing acetylcholine activity. So you think you'd see all these dumbbells here, but initially you end up getting these nicotinic effects instead, and then eventually it goes over into full dumbbells. So don't get too lost in the weeds on that, but this is just how I sort of remember these general effects here, depending on whatever kind of drug exposure might have happened. On the flip side of that, though, what if I have anticholinergic activity here? And so this is, again, many medications do this. I mentioned the antihistamines frequently do this. You're going to find a lot of antispasmodic drugs will do this. A lot of muscle relaxants will do this. A lot of different drugs can do this. And so this is what I use for the anticholinergic mnemonics. This is a really good one to remember because this tells you a lot of the side effects you're going to see with that. So we get blind as a bat. Why do they get blind as a bat? Well, basically because it impairs accommodation in the lens of the eye, so they get mydriasis, and they can't really accommodate very well, so they can't really see all that well. Think about when you get your eyes dilated at the optometrist, for instance. They get red as a beet, so they get a lot of like cutaneous vasodilation, so they appear kind of red. They get mad as a hatter, and so this one's kind of interesting because anticholinergics can cause some CNS effects to where they can get sort of, at low doses, they get kind of sedated in a lot of cases. Like, think about a Benadryl makes you kind of sleepy. But as the doses get higher and higher, they can develop things like, anxiety. They can develop hallucinations. They can develop seizures potentially. And so that's where that Mad as a Hatter come from. Although, I'll tell you, Mad as a Hatter, the actual term refers back to mercury poisoning, which we can talk about at a later date. Dry as a bone because you're going to be drying out all of their secretions. So from a mucous membrane standpoint, from the GI tract standpoint, everything's kind of slowing down, decreasing secretions. And then it'll be hot as Hades. So hyperthermia is another common thing with that. and then finally the heart runs alone. Because again, if you're relieving activity of acetylcholine on the muscarinic receptors on the heart, it's going to speed up activity. Just like if I put atropine in the system, an anticholinergic, it's going to cause heart rate to increase. So this is a really good, handy mnemonic to know. I'm going to probably bring this up a gazillion times in Pharm 1 and 2. So if you know this one, and you know the dumbbells, that's going to get you probably 90% of the way in terms of those kinds of side effects you can see from drugs that interact with those systems that way. Okay. Again, as I mentioned with tone, both systems are constantly active in the body at all times. It's just a matter of which one, kind of how they're feathering the pedals there. So you may find sympathetic may be more active versus parasympathetic and vice versa, depending on the patient's condition there. So just be aware of that. And again, a lot of drugs are going to be interacting with the systems here, as we will see. So again, ways that we can affect the system. So I'll give you more specific examples of how we can directly affect this. So we can give drugs that mimic the effects of the sympathetic nervous system. These are called sympathomimetics, right? So these are going to be things that directly activate, beta receptors and alpha receptors like dopamine and norepi. These ones are pretty easy to remember because we produce them ourselves, right? Well, there's other ways we can do it too. So like, for instance, we can give drugs that increase the release of norepi from those nerve endings, right? We can actually cause direct release of those vesicles, that exocytosis to occur. And that can include things like cocaine, the amphetamines. So when you think about ADHD drugs, this is where a lot of these are going to be working at. We could also use drugs that block adrenergic activity. So we mentioned beta blockers several times throughout the course and how that can slow down heart rate and contractility. There's alpha blockers out there that can lower blood pressure by blocking alpha-1 receptors. And then I mentioned clonidine as well. So again, we can either enhance the activity of the system or we can decrease it, as the case may be. And then there's many cholinergic substances. So for instance, there's acetylcholinesterase inhibitors that we can use to try to increase muscarinic activity. There's anti-muscarinic drugs. This is probably going to be a lot more of the things we'll talk about, as many examples of this. Or I can even stimulate those postganglionic fibers. So for instance, with nicotine, I can do that directly. So that's why if you ever see like nicotine poisoning, that can cause a lot of muscarinic effects in addition to a lot of sympathetic effects as well, because it's focusing on those sort of preganglionic nerve endings there. So anyway, so that's just a general overview. I kind of want to just introduce you to the idea of the topic and, again, why I think it is so important. And it will come up time and time again in Pharm 1 and Pharm 2. So if you want, you can always reference back to this or your other physio lectures and whatnot. And so, yeah, so any questions on that before we get into our Kahoot? Let's see. Kaylee asks, the anticholinergic mnemonic would be dealing with fight or flight, right? So that's a good question. So when you see anticholinergic, does not mean sympathomimetic. Just because I'm inhibiting the parasympathetic nervous system does not mean that I'm up regulating the sympathetic nervous system in those cases there. It just means those are direct effects you're going to see by blocking activity of acetylcholine on those muscarinic receptors there. So it doesn't mean you're going to automatically activate fight or flight, even though it may kind of look like that a little bit, because again, the heart rate's going to go up, blood pressure might go up a little bit, they may be more alert and anxious, so it kind of looks a little sympathomimetic. And actually, that's a really good point too, is that when I see people who have overdosed on a substance and I don't know what it is, right? Because oftentimes they're either unable to communicate with you or they're lying to you, or whatever the case may be, to determine if they were exposed to an anticholinergic or a sympathomimetic is really hard to tell, because again, they look kind of similar. So I think that kind of speaks to your point that the anticholinergic kind of sounds fight or flight response, but there are some subtle differences there, which I'm not going to overload you at this point. I'm probably too far in the weeds as it is. So any other questions before we get into our Kahoot? You're like, no, I just want to review for this exam, so I know what the heck to study for. Right? That's okay. So here is the access code. So if you guys want to start logging in, my only rule for Kahoot is if it's a name that you would not be comfortable explaining to your grandmother, then do not use that name. So keep it civil. I'm sure you've already gotten the talk from Professor Kaplan, though. So you haven't studied, that's not great. Paraempathetic, that's interesting. I've never heard that term before. Now, if you name yourself Dr. Wood, you got to do really well. Otherwise, you kind of sully my name a little bit, so I can't allow that to happen. Hopefully everyone will log in. And I have that sticky board up too as well. So if you have any questions, you don't want to put them in the chat, like feel free to put them on the sticky board, and I will look at that periodically. I might run my Kahoots a little differently than other people, so we'll see how it goes. Got 56 in so far. Let's see, it's 10:41, so I'm gonna go ahead and get started. So I will tell you, there are some math problems on the test, right? Don't freak out though. I'm gonna give you some examples of math problems here. You're gonna have a calculator available. Slide through lockdown browser, calculator is activated. These are gonna be relatively straightforward, easy math problems. I know what you're thinking. Yeah, it's easy for you to say, you've been doing this for a decade. I will give you examples very similar to the test on this. So if you can do the ones here without scratch paper using a calculator, you're gonna be fine. Okay, and again, I'll post this up later so you can go back and retake this if you want and repractice with it. But you should be okay. As long as you have a good understanding of the fundamentals and the concepts here, we should be okay. So let's go ahead and get started here. All right, so for cocaine, which of the following routes of administration has the fastest onset of action? So we're kind of talking about different routes of administration. Which one do you think would be fastest? If I ingested it, if I injected it, if I inhaled it, or insufflated it? This one's kind of a joke question, but I think there's some points that we can make here. Those of you who don't know, insufflation is where you're snorting the medication. You can't see. Do I need to adjust this at all? Can you see? Should I make it smaller? Does that help at all? Oh, still in it. Oh, I'm sorry. It should be caught up. All right, well, I'm sorry for some of you. So yeah, so a lot of you put injected, which is a very good first thought. So, and again, I kind of do this to kind of illustrate some points here. So again, I'm going to be much more tricky on some of these than I would ever be on the test. My tests are always very straightforward. If you know your stuff, you know your stuff. If you don't, then not. I'm never trying to trick you on a question on an exam. So just FYI. So anyway, so the point I want to get to here is that, yeah, different dosage forms. Let's see, I think mine's lagging. I'm very sorry. Maybe reconnect. Maybe that would help. Not sure. So, you know, ingestion would be probably the slowest, right? Because it has to go through the GI tract, has to be absorbed. It's going to be slow, right? You know, injecting it would be pretty quick, right? Because it's going straight to the venous system here. And then snorting, too, would be a little bit slower because it still has to go through the venous system in order before it gets back to the heart. What's interesting, though, with cocaine, though, and something you may learn with certain drugs that get absorbed via the pulmonary route, is that if you think about blood flow, think about where it's going, right? So if I inject something into, say I inject it into my arm, peripheral vein, it has to go through the venous system to the right side of the heart, it has to get pumped through the lungs to the left side of the heart, and then eventually gets pumped up to the brain, right? What if I could kind of skip some of those middle systems there and directly go from the lungs to the left side of the heart and get to the brain that much faster? And so that's actually one of the reasons why smoked cocaine is actually so much more addictive than other routes, is because it hits you so much harder, so quick, that it causes that flood of dopamine and is very, very addictive. So for most drugs, though, if you were to say, yeah, injecting would probably be the fastest, you'd be right 99% of the time. I just make an example here just for, you know, interesting illustrative purposes here. But very good thought for most of you saying injected. Okay. Let's see, which of these drugs would be safest? So based off of the ratio between their therapeutic index, which one of these do you think would be the safest drug? My metal straw, my metal cup is being a little loud. I know some of these letters and numbers. I hope you know a lot of them. There was a few stragglers. I was waiting until the last second. Ah, very interesting. So remember, to look at your units, right? We talked a lot about this during, I think, the 4th lecture there. But remember the difference here in the units, right? You got to know your metric system here. So if you were to look at the actual therapeutic index here between 500 to 5, yeah, that's a 100-fold ratio. That's pretty safe. However, though, if I go 5 grams to 5 milligrams, that's a 1,000-fold difference. Okay. So keep in mind, make sure you're converting everything, apples to apples, oranges to oranges, and that way it'll make sense there, right? So be cautious of that in your units. And this is a common mistake a lot of people make, not just students, but providers can make issues with this all the time. So be cautious. Again, you kind of got the idea that the larger that ratio there, the safer it's going to be, because there's less overlap between what a therapeutic dose might be versus when it would become toxic potentially. All right. Like I said, maybe there will probably be a question like that on the exam though. So again, be cautious when looking at your units. Okay, so getting into definitions, which of the following differentiates a toxicant from a toxin? The toxins are non-biologic in origin. Toxicants are non-biologic in origin. Most pharmaceuticals are toxins, or toxicants are harmful. It's a little bit of an esoteric point here, but again, trying to illustrate, you should know your definitions. I'm glad I saw it on the Kahoot, so we don't do it on the exam though. I hope none of you do it on the exam, but again, look at your units. Make sure you're comparing things equivalently. All right, very good. Yeah, toxicants are typically non-biologic in origin. So like snake venom and spider venom and things like that are considered toxins. For those of you interested in going to derm, like Botox is considered a toxin because it's made by the Clostridium botulinum organism there. Toxicants are non-biologic though. So any drugs really, for the most part, are going to consider toxicants. Again, it's a sort of an esoteric sort of differentiation, but I want you to go back and make sure you know the differences on those definitions there. Understand the difference between pharmacodynamics and kinetics and things like that. Okay. All right. See, drug A, 100 milligrams daily to lower blood pressure by 15%, and drug B, you can give 10 milligrams a day to get blood pressure lowering by 15%. What is true of these drugs here? That these drugs are equal potent, drug A is more effective, drug B is less effective, or drug A is more potent? What could you say here? All right, yes, these drugs would be equipotent, right? So again, just looking off this, we can't tell which one is ultimately more effective or not, right? Because we can only compare these two doses at this time, and they're getting the same effect out of that, right? So what we could say is these are equally potent dosages because they're getting the same effect there. So that's where that term equipotent comes from. But ultimately, I can't say whether B or A is going to be more or less effective there. I certainly could not say that A is more potent because if you look at it, it takes 100 milligrams to get that effect versus B only to give 10 milligrams. Okay, so if anything, you could definitely say B is more potent to get that effect, but I couldn't say which one is ultimately more or less effective. Okay, but this would be an equipotent dosage, and this is good to know too, because like I mentioned with, for instance, like opioids, if I have like comparing morphine versus fentanyl, 50 to 100 micrograms of fentanyl is equivalent to like 2 to 5 milligrams of morphine. If you don't account for that difference in in potency there, and you try to give 2 to 5 milligrams of fentanyl, you're going to kill someone pretty quick, right? Hopefully no one would accidentally do that, but you get kind of the point there. Okay. All right. The hotness or spiciness of a pepper is rated by what scale? Sometimes I include fun questions. I don't know how fun it is, but the Child-Pugh scale, Payne scale, Scoville scale, or Pemberton scale? Do you also get fun questions on the exam? I mean, I think every question I write on the exam is fun, but you will likely have a different subjective opinion of that, so probably not. All business all the time on my exams. Kahoot, so we have a little more time for fun. Yes, very good. Scoville, yeah. So like you talk about like, the Carolina Reapers, like millions of Scovilles and things like that. Yeah, I would not recommend ghost peppers either. Oh my goodness, guys are pretty adventurous out there. Yeah, I'd like to grow some. I actually have some tomatoes growing right now. That was my quarantine project. Okay, which of the following methods of dosing may be most affected by extremes of weight in kids? Oh, that might be good. If we ever meet in person, I can get them. Okay, so age-based, body surface area-based, or weight-based? which can be most affected by extremes of weight? Yeah, so age-based would be it, right? So again, affected by extremes of weight. So if you're just saying, okay, every 5-year-old gets the same dose, it doesn't take into account you could have a really obese 5-year-old or a really thin, small 5-year-old. Okay, so that's affected by the extremes of weight there. So that's one of the problems with that is you're assuming everyone's having the same sort of kinetics, everyone's the same size and whatnot. When you're looking at weight base, that helps to limit that, right? But even then, you could have someone who is quite obese, and it doesn't take into account that now they have a lot more adipose tissue as compared to someone who was smaller than them, things like that. The easiest way to actually account for weight is to use that body surface area measurement there, right? Because remember, it factored in not only their height but also their weight together. So by using those two together, it helps to sort of equalize that out. And so this would be kind of the most exact. Weight base is still pretty good, in which you'll use 95% of the time. But age base is not great because, again, it's assuming every kid's exactly the same within those ages, which we just know is not true. All right, which of the following categories has the least amount of abuse potential? So going back to our controlled substance, this is the least amount of abuse potential. What I say is C 2, 1, 3, or 4. I see a lot of dejected faces out there. We guys will have a good weekend, be able to study. Yeah, very good. C4. Remember, so it kind of goes in kind of reverse order a little bit there, where had a long week. I'm sure you guys have, and hopefully you guys don't have too much after me today, but we'll see. So remember, Schedule 1, the big difference with that is Schedule 1 has no acceptable medical use. It's still considered to have a high abuse potential. So you'll never prescribe that one anyway. It's actually really hard to even do studies with that stuff because it's so tightly controlled. Schedule 2, though, then that's where you will start to have some prescriptions being written for those because those do have acceptable medical uses. That's going to have the highest abuse potential, down to 3, 4, and 5 having the least amount of control over it. So absolutely right. Schedule 4 will be the least there. Schedule 1, though, and again, this is set by the DEA. So like clinically is marijuana, which is federally a Schedule 1, as addictive as cocaine, a Schedule 2? Well, of course not. It's ridiculous. But that's, again, how it's been regulated by the DEA. So that's what we go off of are those definitions. So. All right. So which of the following is true about the intravenous route of administration? So it has the highest bioavailability. Extravasation means a med is placed into an artery. It has a slow onset of action, or medications given accidentally can be removed easily. I forgot to tell you, whoever wins this gets one free answer on the test. So if that provides you any extra incentive, that may help. Very good. It has the highest bioavailability because it's 100%, right? You're putting it directly into the system there. Extravasation would just mean if you're going outside of the vein itself. So that's if you were to blow a vein and start to infuse med into the surrounding tissue. Again, that can be either harmless or it can be actually really, really terrible for that surrounding tissue. Like if you extravasate like phenytoin or like calcium chloride or something like that, it can be really detrimental to the tissues there. Does have a pretty fast onset of action, and that's the thing too, is like once you give that drug, it's gone, right? It's already in the system. You can't really take it back. So that's why you want to always be really making sure that you're doing the right thing when you say, okay, I want this drug to give this patient, because once it's there, it's there. But to Control F these PowerPoints, hopefully you Control F all the answers. And then Control save them into your mind. Let's see. A drug is removed from the market after noting increases in mortality. Which phase trial is this? The phase 3, 1, 2, or 4? Could I explain the blue option? Which one's the blue option? So when I mentioned that, it was extravasation. So remember, that's when if you were to like blow a vein and infuse the med outside of the vein itself, that's extravasation. It's when drug is going into going to surrounding tissue. If you were to accidentally put it into an artery, that would just be intra-arterial administration. It's not done really hardly ever for medications. There's very few intra-arterial meds you're going to do. That's more so done for like blood pressure monitoring and some other things there. So that's what extravasate means there. Yes, very good. Phase 4 trial. So if you take a medication that's out in the market, you're a participant in a phase 4 trial, right? Remember who is involved in all of these trials. Though. Remember phase 1. It's really early on. That's where they've completed the animal testing. Now it's ready for human testing. That's where they're using healthy volunteers, people who don't have the disease in question, and they're just testing to see what the kinetics of the drug are, looking to see safety, side effect, things like that. Phase 2 is where they start to introduce people who have the disease in question, and maybe they're doing it to a couple dozen to maybe 100 people that have the disease. And now they're looking for efficacy in addition to continued safety monitoring. The phase 3 is that final sort of pre-market sort of phase where they have sort of the most people with the disease taking it, and again, looking for efficacy, looking for safety as well. That continues on regardless. And then phase 4, once it's out in the market, kind of everyone's taken, that's that post-marketing surveillance we're doing there. Okay. All right, what's the standard expiration dating for a prescription for a non-controlled substance? Would it be 1 year, 10 years, 30 days, or 6 months? It is a non-controlled substance here. Very good. Yeah. So non-controlled substance is only going to be 1 year. So if you were to write something that you're going to expect them to take all year long, you just do the original script and you do 11 refills. It's like 11 plus 1. When you do that, that's appropriate. You can write 24 refills on there, and it's not going to matter. They're only going to get those 11 refills potentially at a max. Nothing is really like 10 years in terms of expiration dating. Nothing's really 30 days, but 6 months would apply to your C, 3, 4s, and 5s. Okay, 3, 4s, and 5s. Controlled substances can get a total of 6 months in terms of validity of that prescription. Remember, C2s get 0, right? No refills on those whatsoever, so they're kind of one and done. Can you turn on the Kahoot music? It gets me in the zone. I hate the Kahoot music so bad. That's why I always cut it off. But you guys can play whatever music in the background that you want. I won't be able to hear it, so you could always do that. Maybe do like some Motorhead or something like that to get you in the zone. So remember, 6 months for those. C2s, no refills. And then C1s, you wouldn't be prescribing anyway, so that one would be kind of like a trick question if I were to include that. So which I would not do. So, okay. Let's see, what type of elimination is pictured here? So we're looking at drug plasma concentration. We're looking at time on the x-axis here, and we're looking at elimination. What kind of elimination would this be? Would it be considered saturated kinetics, aqueous-based kinetics, first order, or zero order? That's my 2-year-old you can hear in the background probably. He's coming up to investigate what's going on in my room. Very good. That's first order kinetics, right? So remember, it's a constant percentage of drug per unit of time here. So if you look here between 2 to 4 hours and then 4 to 6 hours, again, you're getting roughly 50% of that drug metabolized. That's the half-life here. It's a 2-hour half-life drug, okay? So that's first order kinetics, where the constant percentage per time, versus if this was a straight line, this would be zero order kinetics there, okay? So it's kind of the big difference. So those other two are just made up, so those are not anything. If anything, when you saturate all those enzymes, sometimes you can find drugs that will go from first order to zero order. That's a rare thing, which I'll mention when we come across it, but that's a feature of saturating those enzymes potentially. But it says first order kinetics there. All right, let's see, which of the following occurs after chronic administration of a competitive antagonist at a receptor? Where I see the cell will increase release of drug metabolizing enzymes, the cell will increase the number of receptors at the cell surface, the cell will remove receptors from the cell surface, or the cell will remove all receptors from the cell surface. All right, yeah, absolutely. So remember, we're giving a competitive antagonist, so we're sticking to the receptor, but we're not activating, right? We're blocking that. So overall, we're decreasing activity at those receptors. So the cell can detect that and they say, hey, wait, there's not enough activity going on here. So they'd actually upregulate the number of receptors at that cell surface there. Okay, so it's a example of upregulation there. If it was like a competitive, or I'm sorry, if it was a agonist we were giving, then yeah, you'd likely see downregulation over chronic administration. That's kind of the difference there. Usually you'll never, if a question says like all, always, never, like, those are usually not going to be correct answers. This is kind of a general tip there. And then there's not really any instances where it's going to be releasing more metabolizing enzymes for an antagonist. There's some cases where a cell may try to overcome, may become resistant to a drug. So sometimes like cancer cells can actually develop mutations here to do that, but it's a pretty rare circumstance. All right. So we have a 4-year-old 17-kilogram patient with dehydration presenting to the ER. What's the maintenance rate for their fluids? So again, you should be able to do that 4-2-1 rule in order to determine what that maintenance rate is. I'll even tell you on the test it's a 4-2-1 rule. But you got to be able to figure out how to do the calculation, right? And remember what a bolus dose is too. Bolus is going to be that 20 mLs per kilo, right? And I'll give you those doses on the test, but right, you got to do the actual calculation yourself. I'll even tell you there's one question on the test that's going to be directly related to something like this, so be able to do that. Peter, are you between two ferns right now? All right, what do we got? All right, it's 54 mLs an hour, right? So if you recall the 4-2-1 rule, so what does that mean? Big word here. So if we were to look at how to do this, so looking at this, we have a 17-kilogram child, right? So what is that 4-2-1 rule? So 4, 2, 1. So that means for the first 10 kilograms of their weight, they're getting 4 mLs per kilogram, if I could type, per hour. And then for the second 10 kilograms, you're going to get 2 mLs per kilogram per hour. And then finally for every other kilogram, 1 ml per kilogram per hour, right? This one's pretty easy too, because you only have to use the first two parts of the rule because they're 17 kilos, right? So if they're not beyond 20 kilograms, then you don't have to worry about it. So for that first 10 kilogram of that patient's weight, that 10 out of that 17 is going to be 4 mLs per kilogram per hour times, if I could find my, times 10 kilograms, right? So what does that equal? Pretty straightforward, 40 mLs per hour. Those kilograms will cancel out there. And then for the rest of his weight, because he's less than 20 kilograms, it's only going to be that 2 mLs per kilogram per hour times 7 kilograms. So 7 times 2 is going to be 14 mLs per hour. So in that case there, 54 mLs an hour would be the maintenance rate for that patient. I'm not going to ask you to pick the fluid or anything like that. I just want you to know what the rate's going to be, okay? This is a very good, handy skill to learn early on. See, what if they weigh less than 10 kilograms? That's a good question, Andrea. So let's say they were 4 kilograms. Well, what would you do then? It's even easier, right? So then you should do 4 kilograms times 4 mLs per kilogram per hour. So their maintenance rate would just be 16 mLs per hour. Just that easy, right? So again, look at how much they weigh, see which part of the rules do you need to incorporate there, and then you should be good. So any of you could figure out, okay, well, I know that for that first 10 is going to be 40 mLs an hour, and then if you can figure out that 2 times 7 to get the 14 mLs, you just add these up together, and you got your rate, okay? Now, what if I'd asked you to do the bolus as well, right? Remember, boluses are going to be 20 mLs per kilogram, because this is a one-time dose, so it's not per hour there. If I'd ask you to do that, well, I would just multiply that times 17, and what do you get? Probably 340 mLs if my math is correct. And that would just be the answer, be 340 mLs, okay? So again, you'll have a calculator available to you. You can do these. And again, if your answer is not exactly what's on the answer on the test, then you goofed up somewhere. Okay, so you should be able to come up with the right answer, and it'll be exactly what's on there. I'm not going to put decimals or anything like that crazy on there. I'm keeping it straightforward because we're still pretty early on in terms of your education here. So hopefully that makes some sense. If not, let me know. Send me a question. We can talk it out for sure. Okay. All right, moving on. Metoprolol is considered a beta blocker. How would you classify this drug? Would it be a competitive antagonist, an agonist, an inverse agonist, or an indirect agonist? What would you say? Very good. And again, a lot of times, like the mechanism of action is like directly in the name of the class of drug, right? So if you saw, okay, it's a beta blocker, I know they're blocking beta receptors, so you know it's a competitive antagonist, right? There are other types of antagonists, but 99 times out of 100, we're going to be talking about competitive antagonists here. So be able to identify those sorts of things. If I say something, is a blocker, you just know it's going to be a competitive antagonist. So again, a lot of times we try to make it easy on you by telling you directly in the class name what's going on. Let's see. The receptor that becomes phosphorylated then dimerizes to initiate a cellular action. Going back talking about our different receptor types, would it be an intracellular receptor, an ion-gated channel, a G-protein coupled receptor, or would it be a tyrosine kinase? All right, so it's actually a tyrosine kinase. This is a little simpler. If you remember kinase from your biochem classes or something, that just means to phosphorylate something. So it's right there in the description. But yeah, those are the ones. If you recall back to the different types of receptors, these are really important for like cellular growth. We'll see this comes up a lot with like cancer, but even like insulin receptors are tyrosine kinase receptors here, right? So they have to have two molecules come in. They'll activate the two separate halves of the receptor. They'll dimerize. They'll come together. They get phosphorylated, and then remember that provides a lot of energy, right? Phosphorylated groups have a lot of energy, just like ATP, and that's what then causes the downstream cellular reaction to occur, right? If I said something like the receptor was located in the nucleus to regulate DNA transcription, well, you'd know that would be an intracellular receptor. Or if I said activation of this receptor causes sodium to flow through along its concentration gradient, well, it's ion gated. Ion, sodium, you can make the logical leap there. And then again, G proteins, if I say something has a G protein associated with it, you probably know it's related to that. So again, kind of understand like the differences in terms of how some of these are working. And then two, kind of take that next step and look at the secondary messenger systems we talked about and see how those kind of interplay with one another. All right, why do graded dose response curves exhibit a plateau at the upper end of the doses studied? So it occurs when receptors start to downregulate. This is when lethality occurs. It occurs when all available receptors are bound, or it occurs due to tachyphylaxis. Remember, the graded dose response curve is when we were talking about it, like looking at different doses on a single tissue, or a single subject, or a single something, versus that quantal response where you're looking at a population and you can see is it being like an all or none phenomenon. Did they reach a certain threshold? Are they asleep or are they awake? Those sorts of things there. Yeah, absolutely. When you're looking at that single sort of sample, yeah, when you've bound up all those receptors, that's when you can't get any more effect, right? Once all the receptors are activated, that's it. You can't do any further activation there. If you recall tachyphylaxis, that's kind of that phenomenon that occurs when you're giving a drug and it starts to kind of lose efficacy. And even if you keep giving more of a drug, you keep increasing the dose, you don't really get any further efficacy out of that because you got to give the body time to sort of re-equilibrate, go back to baseline. That was like that example of nitroglycerin that I used where you have to have 12 hours on, 12 hours off in order to make sure that you don't sort of deplete body's ability to respond to that nitroglycerin when they're having chest pain, right? Hopefully lethality is not occurring, otherwise your response curve would probably drop all the way to the bottom, because if they're dead, they're probably not going to have much of a response. Let's see, 10 kilogram child requires acetaminophen 15 milligrams per kilogram. Acetaminophen comes as a 32 milligrams per ml concentration. How many mLs should that patient get? So again, you're going to have a question similar to this on the exam. So you should be able to figure this out pretty straightforward. I'll show you the step-by-step process too when we're done if you can't get it. So be 23.4 mLs, 21.3, 4.7, or 150 mLs. What do you think? And I'll give you the concentration. It's not going to be per 5 mLs. I'm going to straighten out. Just give you the straight per ml concentration, the weight, the dose you got to give the kid. So Lauren's on the move. So like some action shots there. There's my 2-year-old. She's having a tantrum. All right, very good. 4.7 mLs is the correct answer. Do all 45 of you know how you got that correct answer? Let's walk through it and see how to do it. Right. So again, don't get overwhelmed by the numbers. Right. It's real easy to look at that and you're like, I don't even know what to do with these. If you do it in the same stepwise approach every time, you can't go wrong, right? And so again, this is what I do every single day when we're calculating doses for pediatric patients. Either use the PAs or sending an order to me, and I'm checking that, or whatever the case. It's always the same thing, right? So it's really just a 2-step problem here. One, you got to figure out what the dose the patient needs to get, and then you need to convert that to mLs that the patient ultimately needs to receive, right? So how do we do that, right? So again, I'm going to take the patient's 10 kilogram, not 19, but 10. And then I'm just going to multiply that by the dose. Why did I keep writing 19? It's 0, not 9. 10 kilogram times 15 milligrams per kilogram, right? The kilograms cancel out, and what do I get? Well, I get 150 milligrams the patient should receive. Now, again, if you got an answer like 150 mLs, you kind of goofed up, because then imagine trying to give a kid 150 mLs of drug. It's not going to go well for you. He's probably going to vomit all over you. But so now we have the milligrams a kid needs. Now we need to convert that over into mLs. And this is pretty straightforward because we know the concentration, right? We don't have to convert this over at all. We just take that 150 milligrams and we just divide it by 32 milligrams per ml. Okay, and so what do you get? Well, you get 4.7. And I'll tell you the test itself, no decimals even, right? I'm going to make it super straightforward for you. I just want to see, can you execute on this when presented with the information? So I get to the 4.7. So that's how many mLs the patient would need to receive in order to get the therapeutic dose for them. Okay, so again, it's a 2-step process there. Figure out how many milligrams they need, and then take that, divide it by the concentration, and then I'll give you how many mLs the patient should get. Okay. You can practice with it. You can make up your own problems if you want. Practice with your study buddies. You should be able to get it pretty straightforward. I just want anyone to be, I know you can all do this. I know you're all smart enough to do the simple math, but it's the kind of getting over that mental block of like seeing all these numbers and stuff and being able to deal with that. So anyway. See, a 70 kilogram male takes 400 milligrams of a drug with a volume distribution of 2.4 liters per kilogram. What is the initial concentration? And here the formula that you need, remember, it's C0 equals dose over VD. So you know what the dose is. We can figure out what the VD is. You can get the concentration. What do we think? This one's a little more involved because you got to do one extra step here to figure that out, but we'll see if you guys can get it. Again, you're going to have a test on the question on the test that's going to look pretty similar to this. Different numbers, but it's going to be pretty similar in terms of process in order to how to figure this out. Yeah, I know some people like the Kahoot music. I prefer awkward silence. I think that really puts me in my zone. So that's why I go with that. I say the more awkward the situation, likely the better it is. Very good, very good. So let's see how we do this on a step-by-step process here, right? So what are we going to do? So going down again, so we have a 70 kilogram male, and we know that the volume distribution is 2.4 liters per kilogram, right? So basically I just have to multiply that out to get what this patient's particular volume distribution is itself. Because again, when you're doing that equation, remember it's going to be C0, that initial concentration, is equal to that dose divided by the VD. So to get the VD, you got to know it in liters in order to be able to compute this, right? So I'm going to do 2.4 liters per kilogram. What does that equal? Well, I don't know the top of my head, so I'm going to look it up. I'm going to say 70 times 2.4. It's 168. So that patient's particular volume distribution is 168 liters, okay? Well, now I know the rest of it. I just take that 400 milligrams, which is my dose, divided by 168 liters. You can see that's how you get the concentration in milligrams per liter in this case here. So if I do 400 divided by 168, I get 2.38 or roughly 2.4. So milligrams per liter. Okay. Again, the math is going to be fairly straightforward. If your answer looks nothing like what the answer choice is, then you probably goofed up somewhere. But again, just follow that step-by-step process there. Think about your units, where they're canceling out and all of that. You should be able to come up with your correct answer there, okay? That's probably the most complicated it's going to get in terms on the test for the math stuff. All right. How long does a drug company have on a patent to make their money before it expires? Is it 15 years, 10 years, 5 years, or 20 years? How do we access the calculator in Respondus? I activated it, but actually I don't have Lockdown Browser to know how to get to it. But I've had other tests where they've done it before. I think there's a button somewhere, if I had to say. But I definitely activated it. I double checked that myself, so it will be there. Otherwise, you have the ability to publicly, well, I guess not publicly because we're still in COVID times, but you can tar and feather me via remote. I'll set up some kind of contraption or something to allow that to happen. But anyway, yeah, so looking at this, remember when the drug company, when they apply for that investigational new drug license or patent with the FDA, that starts a 20-year clock, right? That also means that's when they can start doing their clinical trials. So if it takes them 15 years to get through clinical trials, they only have 5 years to recoup on their costs by selling a brand name drug. After that 20 years is up, then that's when generics can start to come out at a lower cost. If they can get through it in 5 years, then they got 15 years to make up on that, right? So again, it's always going to be 20 years regardless. It just matters in terms of like how much time they had to spend in the clinical trial sort of setting there. So that's the general thing with that. Again, and this test too is like it's easier because, you know, in pharmacodynamics, a lot of it's conceptual stuff. A lot of it is definitions and things like that. So that's like kind of the majority of the test. When we get into Pharm 1 and 2, that's where the difficulty kind of picks up because now we're like applying stuff. We're saying, okay, we learned about all these drugs, but how in the heck do we even use them in conjunction with like kind of what you learn in your medicine courses and things like that. So anyway, which change would decrease the volume distribution for a hydrophilic drug? Dehydration, increased plasma protein binding, increased tissue protein binding, or edema? What do we think? Very good. There's actually 2 right answers on here, which again, I'll never do on a test, but again, I'm trying to illustrate some points here for you. So remember, anything drawing that medication back into that central compartment or into the bloodstream that will increase that concentration is going to lower the volume of distribution, right? So in this case here, if I have a hydrophilic med, likes to hang out in the water, if I were to get dehydrated, I'd then concentrate that into the bloodstream. Because again, your body wants to keep blood volume up because it wants to keep blood pressure under control there. So dehydration would do that. Also, if I have a bunch of proteins in the blood holding on to all that drug, keeping it in the blood vessels, then that's also going to decrease that volume of distribution because more of it's being stuck there in the blood itself. However, if I were to have, say, a drug be extensively bound out in the tissues where it's going to hold on to it and sequester it there, that would increase the volume of distribution. Similarly, increasing the amount of body water, extracellular water that the drug can partition into. So if I have like ascites or something, or pitting edema, or wherever the fluid may be holding up, that's also going to increase that volume of distribution, right? So kind of keep that relationship in mind between those in terms of how that's going to affect the VD. Because again, that can affect how much I need, how do I need to adjust my dose, because my serum concentrations are going to be kind of affected by this as well. If I lower that VD, more drug is there in the blood, which means my concentration's higher, which means I could maybe see more toxicity potentially. All right, let's see, in phase 1 trials for a new drug, who are the test subjects? And I already gave this one away, but this will be easy for you now. Is it laboratory animals, patients with the disease state, patients without the disease state, or pregnant patients and children? Yes, very good. Patients without the disease state. So recall those phase 1 trials. That's where we're initially just testing to see what sort of safety and kinetic profiles we can see in those patients there. So we do it in healthy patients without the disease state, right? That's part of the clinical trials there. So there's phase 1, 2, 3, and we mentioned the post-marketing surveillance, which is kind of your phase 4. Anything done in animals is the preclinical testing, right? So that's all going to be preclinical, so that doesn't really count here when we're talking about the clinical trials, because preclinical. Patients with a disease state don't really factor in until phases 2 and 3, okay? So phase 1 really is just going to be people without the disease state, healthy patients. Again, you would never do just pregnant patients and children, because those are a protected class of individuals. We'll learn about those more in EpiBio next semester, so just wait for that. Let's see, which of the following has an inverse effect on aqueous diffusion across a biological membrane? It's an inverse effect, so difference in concentration, thickness of the membrane, surface area, or lipophilicity. So as this thing goes up, the other one goes down, being an inverse relationship. Or as I increase this factor, the flux goes down. All right, so thickness of the membrane is correct here. So makes pretty good sense too. If you imagine like a drug trying to penetrate through the skin, if I apply it to a large surface area, more drugs are going to get absorbed because it just has more contact there, so you can see more absorption. So that's going to be a proportional relationship. Difference in concentration. The bigger the difference is, so if I increase the concentration on the outside, it's going to force more of that drug through, so I get more flux. And then lipophilicity too. The more lipophilic it is, the easier time it has crossing all those membranes there. So really it's this thickness is the only one that has an inverse relationship. So like again, if you're applying a drug to your sole of your feet versus your armpit, typically you're going to see less flux in the soles of the feet because it's a much thicker membrane it has to try to cross over, right? Versus say like the rectum is a very thin membrane. A lot of flux happens in those, okay? All right. So inhibition of CYP3A4 by grapefruit juice would cause which of the following outcomes? Would it cause rhabdomyolysis due to elevated levels of a drug called simvastatin, which is metabolized through CYP3A4? Or would hyperlipidemia be caused due to lowered levels of simvastatin? So again, you don't know the drug specifically, but let's just say for arguments that it's metabolized through CYP3A4, which is why I'm asking the question here. If I'm inhibiting CYP3A4, what's going to happen? Are the drug levels going to rise, or are they going to lower? Very good. So remember, CYP3A4 is going to be metabolizing this drug. So if I inhibit that enzyme, I'm seeing less metabolism. Less metabolism means more of the drug is sticking around for longer, so levels are going to rise, right? If I had said, what if I gave a CYP3A4 inducer? So for instance, like the drug used for tuberculosis called rifampin is an inducer, that would lower levels of the drug because it's actually inducing more of the enzymes, more able to readily metabolize the drug, and the levels drop. Okay, so have a good idea of that relationship between if I'm inhibiting the enzyme, what happens to the drug levels versus if I induce the enzyme, you get the opposite effect there. Okay, and people still have trouble with this even through Pharm 1 and 2, so don't worry if you don't get it now, but have an idea of what that process is, what's going on there. And last one, which of the following is not required but recommended on a prescription for safe use? The strength of medication, the medication brand name, the provider signature, or PRN indications. So it's not required but recommended by me mainly. All right, very good. You probably could count medication brand name. I don't necessarily think that's necessary. If you're trying to delineate between like an extended release or an immediate release, that could be included because that does help clear things up. But PRN indications is so important. I think a lot of people don't put it on their scripts either because they think it's just implied by the drug, or they just don't include it for whatever reason. So and again, this is a really important one for my Joint Commission for like hospitals too, where if we're not including our PRN indications, like they ding us for that all the time. If it just says PRN for what, right? You got to be really specific with this. So anyway, so that's that. Strength of the medication provider signature has to be there, right? Even if it's an electronic signature for like non-controlled substances, has to be on there. Strength has to be on there as well, right? So those are the main things. Okay, let's see. So that's it. Let's see who is the winner. Let's see, number 3, Strombolus. Who's Strombolus? Announce yourself, perhaps. Nobody. How about GOT fan? Hopefully not season 8. Peter is Strombolus. Very good. You got 3rd. GOT fan. Who is that? You can speak to me. Oh yeah.
That's
Andre? Okay.
Jill.
Very good. Very good. And who's not Aaron D? I'm assuming not Aaron. Whoa, that's a real head scratcher there. Oh, I see a couple of people trying to announce that they are not Aaron D. Who is it really? Is it Molly? Okay, very good. So as I said, you get to have one free answer for the test, and that free answer is C. So please don't tell anyone what it is. Use it at your own discretion. So anyway, just kidding. I always do that joke, and it never gets old for me. So I've been doing that for like 6 years now, and it's still funny. Anyway, so I'm gonna go ahead and most of you are probably getting your hopes up and dashed immediately. Anyway, so that is it. Thank you so much for joining me today. That's the end of your first Pharm class. So congratulations getting through that. It only gets tougher from here. So sorry, but it is what it is. And good luck on the test. If you have questions, please email me early so I can get back to you in time. I'll try to respond to you as best I can. If nothing else, you guys have a wonderful weekend, and I'll post up the Kahoot and video for that sometime today, maybe tonight, so you can go back and review it. I'll put a link for the Kahoot so you can retake it. So thanks a lot, and I will see you all later.
Dr. Wood?
Yes.
Are you? Can you answer one question?
Only one question. I'm just kidding. Yeah, I can stay on. What's up?
Okay. No, I was just wondering if you could explain the question again about the one that compared drug A and drug B and the equipotency.
Yeah, so you could have drugs that maybe more or less effective than one another, right? So, and you can have drugs that are maybe more or less potent than one another. But when you find that meeting point where you can get the same effect of two different drugs, even if they're the same different doses, then that's considered to be equal potent dosages, right? So I mentioned like 100 micrograms of fentanyl gets the same analgesia as say 5 milligrams of morphine, right? Even though very different doses, they get the same effect out of that particular patient. So those are equal potent dosages. Okay, it doesn't say which one's ultimately more effective or less effective, but I can certainly say morphine is less potent than fentanyl because again, it takes 100 micrograms of fentanyl to get the effect of 5 milligrams of morphine. So I can say fentanyl is more potent, morphine less so. But ultimately, I can't tell what their max efficacy is because I'm not dosing for that. But I can say they're equal potent at that particular dosage.
Okay, thank you.
Anything else? All right, guys, have a great weekend. See you later.